Hi, welcome everyone to this fourth and final webinar of the Alliance for Pulmonary Hypertension. My name is Rob Platika, and I'm a project manager with Admedicum and our sister foundation, Partners for Patients, who is supporting the Alliance for PH as the secretariat for the last 4 years now, and we'll be working together again next year. So we're very excited about that. Before I pass it over to Pisana for a recap of all that the Alliance has done, just a few notes. One of our speakers from Japan sent in a recorded presentation. It's in English, but yeah, just so you know that later on, I'll be queuing that up. And our colleague Dina from Latin America will present in Spanish. And because of that, I think it's important that we all try to use the Wordly AI tool today so that we can understand Dina. So Wordly provides real-time translation and captions in over 50 languages. To access it, you can click on the link that I shared in the chat and then select your language. And then you can either read or hear and read the captions of what people are saying. And if you plan to listen to the translated audio, just remember to turn down the volume or mute the Zoom volume so you're not hearing two streams of audio. Otherwise, you'll hear the presenter speaking English, and yeah, you'll be able to read along in your own preferred language. And if you're having any questions with that or with anything else in the webinar, please let me know in the chat or via private message to me, and I'll do my best to try to support you. So with that, I'd like to pass it over to Pisana Ferrari, who is the Secretary General of the Alliance for Pulmonary Hypertension, for the 2025 recap. Thanks.
Thanks, Rob, and thank you everybody for joining. I will now share my slides. Here we are. I hope you can all see them. So today I'm just going to briefly be telling you about what the Alliance for Pulmonary Hypertension has done over the past years. Now, this slide is the homepage of the Pulmonary Hypertension Knowledge Sharing Platform, which is a digital hub that hosts all of the Alliance's activities. I've shown it with little arrows. There's the PH library. We have a latest news section, a section on webinars, and this is our new initiative from this year, the PEP Talks. And I will be presenting very briefly on each one of these sections of the website. So the library has, as today, 2.5 years after it was launched, 900 expert curated resources, of which 200 were added in 2025 alone. The content is entirely translatable in 40 languages, and the topics that it covers are it's a very broad range of topics, which goes from preclinical research, clinical trials, diagnosis, treatment, surgery, but also the overarching themes of quality of life, health literacy, e-health, of course, which is a very important topic, and patient-doctor communication. At present, as far as we know, and to the best of our knowledge, this is the only comprehensive multilingual pulmonary hypertension repository worldwide. Our news section is the most dynamic part of the platform. There are 15 to 20 new entries per month. These then feed into the library for ongoing access. So this is timely information from authoritative sources, so scientific journals, magazine, other patient associations, institutions, etc. They feature expert-curated summaries and always the links to the original articles for reference. And again, the content is translatable into 40 languages. Here you can see what it looks like. So you have a little photo, an image, and a short summary, and then you click into it and you see the rest of the article. I think the news section provides information as events unfold, so it serves as a bridge between the healthcare professional community and patients. The webinars, we've had 3 live events this year, quarterly. Today is the last one for the year. The topics were also very broad, included clinical trial results, the Global Patient Survey, reports on World pH Day, conference highlights, news about the new inhaled therapies, advances in lung transplant, and also early detection progress. The slides and the recordings are online for ongoing access, and we had speakers from 11 countries, including healthcare professionals and patient advocates. And they've had 3,000 views. The impact is that this is an ongoing reference for patients, families, and healthcare professionals. It's there to stay, and it can be accessed at any time without any password. You just enter the website and go into it. The PEP Talks are a new initiative we had this year. They are short videos that are done by patients who share tips and advice for everyday life, essential strategies for daily living, as well as advocacy skills. We've published 14 so far. There are 4 more coming soon before the end of the year. We had speakers from 13 countries and a very diverse group of people with different types of pulmonary hypertension, different ages, treatments, and also life situations. The videos, again, are online for anybody who wants to see them. And so far, they've had almost 3,000 views. So this is really authentic patient-to-patient knowledge sharing in a very accessible language, totally jargon-free. One final slide about the key metrics from the old time, so from when we launched in 2023. So there are over 900 resources in the website, in the library, which have had 22,000 website views from 9,000 visitors in 127 countries, and we have over 4,000 social media followers. So with that, thank you very much. And I will now hand over to Professor Marc Imbert, who's our guest speaker of tonight. Thank you.
Thank you. Thank you very much, Pisana. Hi, everybody, and congratulations on what you have achieved with the Alliance. I think it's a great partnership and a very, very strong group. So I'm very pleased to follow you regularly and to lecture online today. I'm going to share my slides. Okay, I think Rob, you can see them.
Yes, we see your whole screen. Now we see it in presentation mode. Perfect. Thank you, Professor Imbert.
Thank you very much for your invitation. And I've heard very well that Pisana wants no jargon. So I will try to be jargon-free as much as I can. So the wrap-up of the key 2025 pH scientific developments, I will focus a lot on what is very important for patients that the year of Activin. So I will try to make it as simple as possible, but also, of course, I'm ready to address your questions. So I have some disclosures. Some companies you may not have heard of, others are more famous. And most, if not all of them, have been involved in drug development in pulmonary hypertension. So what is the problem in pulmonary arterial hypertension? Well, the problem is, in fact, quite simple. The flow in your pulmonary arteries is difficult to handle because the wall of the vessels, the wall of the tubes in your lungs, which carry the blood from the heart to the lungs to be oxygenated, you see the wall of the arteries is very thick, very enlarged, and this is what we call pulmonary vascular remodeling. And for many years, people thought that this remodeling was mainly leading to a contraction of the vessel because they have a lot of muscle. And indeed, the pulmonary vasodilators, they do work in pulmonary hypertension, but they don't work sufficiently because the vessel remain very thick, they remain remodeled. And what we try to do, we try to develop new possibilities to try to reverse that remodeling. We are not sure yet that we managed to do that, but we try to do it. And there is a very important family of hormones which are very important in the body and in the pulmonary circulation, that the BMP activin TGF beta signaling. And you see it's complicated. It's complicated because it is a fine-tuned balance between two main families of hormones, hormones which target through TGF beta, activin, and nodal, which lead to remodeling, and another family which is mostly involving BMPs and GDF, which target the BMPR2 and which leads to anti-remodeling. And you see in a normal healthy lung, in a normal healthy pulmonary circulation, you have a well-balanced signaling through the two pathways. In pulmonary arterial hypertension, there is an imbalance with too many messages leading to pulmonary vascular remodeling. You see here the orange bubbles are more important than the green bubbles. And there is therefore too much signaling favoring what you see at the bottom left of my screen, leading to remodeling. So what we try to do, in fact, we try to interfere with this remodeling. And there are many ways to interfere with the remodeling, but the only approved drug in 2025 is what we call an activin signaling inhibitor. It's called sotatercept. It is a biotherapy, meaning that it is a therapy made of normal human immunoglobulin. You see, it's a human immunoglobulin, so a human antibody, but it is a fusion molecule with, on one hand, the constant fragment of the antibody and the extracellular domain of the activin receptor. So in a pulmonary hypertension status, you have too much activin leading to proliferation. And with this little drug, it works like a tool which will trap the excess activin in an attempt to rebalance pulmonary vascular homeostasis. So there is an attempt to rebalance anti-proliferative and pro-proliferative signaling pathways. Of course, it has been a very long and difficult task to develop the whole clinical trial background to convince the community that these drugs could be efficacious. There were 4 major articles in the New England Journal of Medicine. It's very rare to have so many articles in the New England Journal of Medicine because it's very competitive to publish in that journal. And you see here, this is a phase 2 trial, meaning that this is a proof of concept trial. It was published 4 years ago, and it was the first time ever that in humans we could show that adding sotatercept, it's an injection every 3 weeks, like the biotherapies usually used in, for example, asthma or other chronic disease. So it's a biotherapy, and it's given on top of maximum therapy. And you see that add-on sotatercept in that paper was shown to improve the pressure in the pulmonary circulation by 20 to 34% on top of maximum tolerated therapy. And then there was what we call a pivotal trial published 2 years ago in the New England Journal of Medicine. And in this trial, we could show that if you add sotatercept on top of established therapies, you can improve walk distance and a series of secondary endpoints. But what was very important, and that was published in 2025, and I will focus on that today, what was very important was to show that sotatercept could be interesting on top of maximum therapy in people with a high risk of death. That's a critical question for people with PAH when they are treated with all available therapies. If we had sotatercept and if they have a high risk of death, will we reduce that risk? And similarly, can we treat the patient as early as possible within the first year after diagnosis? So early intervention and intervention in patients with a very high unmet need. So here, this is the paper we published at the American College of Cardiology. It was in April at the American College of Cardiology in Chicago. And in this paper, we just showed that in patients with PH who are in functional class 3 or 4, meaning that they are short of breath, at rest, or for usual activities, despite maximum therapies, the addition of sotatercept versus a control placebo, does it lead to less frequent deaths, lung transplantation, or hospitalization of more than 24 hours due to PH? And because we are very careful with our studies, and because we don't want to expose patients at an excessive risk, there was an interim analysis. This interim analysis was prepared to be read after half of the events needed to conclude definitively on this trial. So something some of you may not know very well, in clinical trials, we have statistical analysis which help us to establish the number of patients treated or the number of events needed for conclusively concluding on the intervention. And here the primary endpoint was an event. So you needed 118 events to be sure that you could answer properly to the question. But because it is a study based on very hard endpoint, death, transplantation, hospitalization, it was decided to have an interim analysis when around half of these events, so 59, were seen. So this happened in July 2024. And as you can see, at the interim analysis, the curves separated markedly. You see the red bar, the red lines are on sotatercept, the placebo lines are the blue line, and you see that both curves separated very early after a few weeks, and they were very different. And to make a long story short, in simple words, the relative risk was reduced by 76% on sotatercept in that group of patients with a high risk of death. Based on that, at interim analysis, we make statistical analysis, and you see that the p-value was less than 0.0001, meaning that there was one chance in 10,000 that this was due to chance. So because of that, the Data Monitoring Safety Committee recommended early trial determination, and both the sponsor, the company Merck, and the steering committee, and I was the PI, the primary investigator of the study, we all decided to terminate the study in order to allow all patients to be on active sotatercept and to stop the sotatercept placebo arm. So if you analyze the primary endpoint, you understand it was a composite endpoint. It was either death or lung transplantation or hospitalization. You see that on sotatercept, there were 7 events of death, 1 event of transplantation, and 8 events of hospitalization. On placebo, it was around 13. It was not around, it was 13 placebo deaths, 6 placebo lung transplantation, and 43 hospitalization on placebo. So this was very different. But of course, because the study was terminated early, the power of the study was less potent to study the secondary endpoint, and we could not make statistical definite assumptions. However, for those of you who do not know statistics well, you see that the risk of death was reduced by 58%. The risk of death or transplantation was reduced by 66%, and some measures like walk distance was improved by 63 meters. So altogether, this study was interesting because it showed on the basis of very hard endpoint that there was a strong difference in favor of the activin signaling inhibitor sotatercept. That being said, there are more side effects on sotatercept, the most important ones being bleeding, mostly nasal bleeding, what we call epistaxis, or nasal bleeding, telangiectasia, little red spots on the skin, and some other side effects like increased hemoglobin, because in fact this drug was initially developed to treat anemia. So altogether, the results are interesting with a good benefit-risk balance. So the Zenith summary, I'm not going to read through it, but just for the sake of good quality communication, it was a study which was designed to assess major morbidity mortality events, and it is the first study to be stopped early at a pre-specified interim analysis for efficacy. And because of that, all the patients were invited to roll over to the active long-term safety study, SOTERIA, and the other ongoing study was also terminated, and I'm going to describe now the other ongoing study. It was the Hyperion study, which is a study meant to study patients within the first year of diagnosis, but there was an overlap with some patients with a high risk of death, so it was regarded as not ethical to maintain patients on placebo in Hyperion. So Hyperion was also studied in PH, and it was also published in 2025. Valerie McLaughlin presented the study at the European Respiratory Society meeting. And as I just told you, following positive Zenith interim analysis, in addition to the overall sotatercept clinical data, the steering committee and the sponsor decided to stop Hyperion due to loss of fair clinical balance in that study. So the study was terminated before its interim analysis. So here the patients had PH and they were diagnosed within the first year of diagnosis. They were in functional class 2 or 3, and they had a risk of death of 6 or more. They were less severe, but because it was 6 or more, there were some patients with a high risk of death. Very simple study, either placebo or sotatercept, and the time to event was similarly studied as in Zenith, but here you see it was a softer endpoint. Of course, there was death, but there was also hospitalization like in Zenith, transplantation like in Zenith, but the soft part of the endpoint, which was the most common endpoint seen, was any deterioration in performance in exercise measured by 6-minute walk distance testing due to pH. And you see here you have a very clear discrimination between the two curves. The hazard ratio, so the relative risk was 76% less on sotatercept. But you see here, there was no difference in terms of death. There were more hospitalization on placebo, but there were many more deterioration in performance. So when you analyze the safety, it's interesting to see that the safety profile is the same than in other studies. More bleeding, mostly epistaxis, more serious bleeding events, 6 versus 3, more increased hemoglobin, and more dot spots on the skin due to telangiectasia. What is interesting is that there were some pericardial effusion seen, but they were as common on sotatercept and placebo. Pericardial effusion means water around the heart, which is a common symptom in severe pulmonary hypertension. And you see that in the Soteria study, we now have, the Soteria study, that's the safety study. And now we have data after 2.5 years of median follow-up. You see that the most common side effects are bleeding. And you see here a focus on bleeding, 2/3 epistaxis, 1/3 non-epistaxis. Telangiectasia is never severe, while bleeding can be severe or serious in 9% of cases. And you see that pericardial effusion, sometimes severe, occurs only in 2% of patients in that study. However, in 2025, there were reports of pericardial effusion from the US experience, and we know now that almost 10,000 US patients are treated with sotatercept. So we had a clear look to the STELLAR phase 3 and the ZENITH phase 3 trials. And we don't see more pericardial effusion in placebo group and in sotatercept group. However, bear in mind, when you are on sotatercept, you are improving, while you are on placebo, you are not improving. So there is a paradox to have as many pericardial effusion on sotatercept. You would expect slightly less if the patients were improving and if the pericardial effusion was due to the severity of PH. So there is a flavor of slightly increased risk of water around the heart, and it is reminiscent of another 2025 information. So, of course, because sotatercept was efficacious in phase 2 and phase 3 studies, other companies, as always, are trying to find better activin ligand trap. And here you see one called cibotercept, developed by a company called Keros. And this drug was developed in order to spare BMP binding, in order to be less problematic in terms of safety signals, at least in theory, in terms of, for example, increased hemoglobin. But the big surprise with this drug was that exactly a year ago, the company had to stop the 2 top doses of the treatment because of pericardial effusion. So, surprise, surprise, it was the first time we heard about that on an activin ligand trap. And 11 months ago, exactly, Keros Therapeutics announced that it terminated that trial because there were new pericardial effusion seen. So pericardial effusion will need to be understood. We think that it is due to the drugs. We think it was more common at the doses tested of cibotercept. It is reported on sotatercept, and now the prescribing physicians are aware of that side effect. And now I would like to stop by a 2025 final comment on sotatercept in my country. So in France, we have what we call early access. When a drug is approved in Europe by the EMA, but not yet reimbursed in terms of cost agreement with the pharmaceutical company, we can prescribe it in a definite population, and this definite population evolves over time. And the first early access program, AP1, was for patients with idiopathic, irritable, associated with drugs, associated with connective tissue disease, associated with congenital heart disease corrected PAH in functional class 2 or 3 on maximum therapy, including intravenous or sub-Q prostacyclin. And very fast, I wanted to show you that we now have treated more than 300 patients, but here that the first 100, the patients were rather young. You see, they were 50 years old, mostly females, around 70% females. All of them were on parenteral prostacyclin, except one, which was a protocol deviation. 1/3 was on anticoagulant. And you see here that they were doing better than in the randomized control trial. At baseline, their walk distance was 443 meters. Their BNP was very low, and they were having a normal cardiac index. And you see here that the patients did well. There were 4 deaths and 2 lung transplantation in the most severe patients. And you see here that the patients improved their walk distance by around 30 meters, sorry. And they improved also their hemodynamic quite importantly, and their NT-proBNP decreased even further. The patients were more and more in low risk. You see the low risk strata went from 44% to 2/3, but there are, of course, some patients who are refractory to that treatment, as you could imagine. A key question from the patients is, can we stop epoprostenol when we are doing much better? We have tested that, and we have that tested in 23 patients. But of course, they were very carefully monitored. And bear in mind that these people had near normal hemodynamics while on sotatercept. And right now, we have very good discontinuation rate because 16% of our patients could stop epoprostenol. But this is, 16% of patients, I'm going to go back one slide, could stop their epoprostenol, but this is still work in progress. And here that the safety of the global program, and bear in mind that despite the good quality data in randomized control trial, 16% of patients had to stop sotatercept during the early access, some because of lack of improvement, some because of pericardial effusion, etc., etc. Sorry for that unclear statement. So here, when you look at the adverse events on sotatercept, as you would imagine, the most common are bleedings and telangiectasia and epistaxis. So exactly the same than in the randomized control trial. Pericardial effusion do exist as well, and there are some cases of oxygen decrease in the bloodstream. We can discuss that later if you wish. So from that French early wave of the early access program, it's promising. It's possible to consider weaning of prostacyclin, but that's not the initial plan. But we are working on that, and we are going to do randomized control trials on that. And the safety indicates that bleeding, telangiectasia, and nasal bleeding, and sometimes pericardial effusion can occur. So we are lucky to have now a 4th pathway for pulmonary arterial hypertension after the 3 first pathways, which are still very important. And I repeat over and over that prostacyclin pathway remains a very important pathway to consider. And when we consider stopping it, it's really after a very careful case discussion and patient involvement. As you remember, this drug family is now in the treatment algorithm of the World Symposium, and it will be considered in the future guidelines. So I thank you very much for your attention. I'm going to stop sharing, and I wish you all happy holidays.
Thank you very much, Professor Humbert. I know you have another meeting coming up soon, but do you have a few minutes for
fine.
questions?
I'm fine. I moved it.
Great. Okay, thank you. I'll read a few questions out for you, and of course, if you can't answer them, because sometimes people ask questions that are maybe too specific to their situation, feel free to say, I can't answer that one. But I think all of these are good for the entire group. Melanie asks, so if I understand well, previous PAH specific medications did not manage at all to reverse vessels remodeling. I thought they did at least partly.
Yeah, bonjour, Melanie. It's a good question. It's also always the balance between hypothesis and facts. In fact, the PAH traditional drugs were tested in animals, and in animals, they were leading to, at least in part, reverse remodeling. On top of that, these agents had also some effects in vitro when you work on cells in the lab, in the laboratory. But we know that in patients, it decreased the pulmonary vascular resistance. But most of the patients who were tested in terms of local remodeling, for example, patients who had sadly a car accident or who died suddenly and who had a postmortem, while they were doing very well, they all had significant remodeling. But I don't know on sotatercept if that remodeling is reversible because it goes quite fast. So maybe it's another mode of action, which could be recruitment of vessels. So the answer to Melanie is indeed that the currently available families of drugs do not reverse remodeling, at least in humans.
Thank you. The next question was actually asked in French, but I'll read you the English translation, and hopefully this person can follow along with the captions. Does France plan to broaden its criteria for access to sotatercept?
Yeah, it's very French-centric. I'm not going to spend too much time, but indeed, and it's already the case. So the AP1 was exclusively for patients on parenteral prostacyclin, but AP2 was for patients on maximum tolerated drugs, including triple oral. So it has, and early access should be history. The drug is approved, and we should have commercial accept throughout Europe. I know it's a big complex issue, the reimbursement. It's not my job, but I hope it will come everywhere.
Thank you. Our friend Luis asks, I'm curious if you can delay the time to the need for using epoprostenol, treprostinil by providing sotatercept before that step to epoprostenol. Very nice for the quality of life of patients.
Yeah. Good evening, Luis. So indeed, that's important. Of course, it was not the key endpoint. But when you analyze the key endpoint, you had patients, for example, in Stellar, who were on placebo. They were hospitalized because their pH was not doing well. And because of that, there was a decision to initiate therapy. And very often in patients on oral, double, or triple, it was the next step, epoprostenol infusion, either sub-Q or intravenous. So it has not been tested this way, but it is in the background. It was the case in some patients.
Thank you. And our final question comes from Pisana. Weaning off perinetre, sorry, peri periteral therapy. Said that wrong. Parenteral
Parenteral.
therapy.
Parenteral.
Parenteral. Thank you. Parenteral therapy is the big hope for patients. Are other countries also doing this, and is France planning to continue?
Yeah, that's merci beaucoup, Pisana. That's a very good question. And you know me, so many countries play with it. So it's good to play. It's very good to be nice and to consider stopping the drug when it's inconvenient. But you need to be very careful if it is not a life-saving drug. So the first thing is to be entirely sure that we do not expose patients to an excessive risk. And that the reason why I know people do it in Germany with very good quality of follow-up. I know that some people do it, for example, in the United States of America with very good follow-up. But once again, what I want is to do it in a randomized controlled trial fashion. And we have put together a proposal which should be accepted. And of course, people will be allowed to do it according to their clinical feeling, but there will be a study in which the patients will be in the best possible security status. And that's my big hope, is that we can make the patient's life better. My dream is to reverse and cure the disease, but at least make your life better. But do not take too much risk and go to expert centers when you want to discuss that. So thank you, Pisana, for asking that question, which is essential.
Thank you, Professor Humbert, for your talk today, but also your unwavering support of the Alliance and of people living with PH over your vast career on behalf of the Alliance and also the people here today in the webinar. We just want to say a big thanks for just being so accessible to all of us, for explaining, for answering our questions so well. And we truly appreciate and are lucky to have you as part of the community. So thanks a lot for everything, both today and overall.
Thank you, Robert. And happy holidays again. I will answer Ingrid's question in French. It's a personal question.
Yeah, please feel free to send, people a private message or yeah, we couldn't get to all the questions right now. And some were maybe a little bit personal too, but thank you for seeing that. And yeah, with that, I want to invite our next speaker to the stage to kind of give us a 2025 recap from the United States point of view. And that's Colleen Brunetti. Colleen is living with PH, is a patient advocate. She's a public speaker. She's a award-winning author, and she's going to tell us more about what was going on in the United States this year. Colleen.
Great. Thank you so much. Hello, everyone. So happy to be here. Let me just get my slides up and see what I can do here. Let's see. Okay,
Slides are up.
great. And is it in presenter view all right for everyone?
Yes, now.
That works?
Perfect.
Okay, wonderful. All right, so hello from the United States and freezing cold Connecticut. If you don't know the US terribly well, we're right between New York City and Boston, where I'm calling from. So let's see. There we go. All right. So just by way of brief introduction, my name is Colleen Brunetti. I have been living with pulmonary arterial hypertension for almost 17 years. This is me with my family. The tall kid in red was just about 18 months old when I was diagnosed. And we were very, very blessed to adopt my daughter a little over 11 years ago. And that is my husband, Brett. We were college sweethearts. So this is me and my lovely family. I have been with this same PH specialist since I was diagnosed. Count myself very, very lucky to be a direct beneficiary and recipient of all the interesting research that we just heard about for these many, many years. So I'd like to start with an update from the Pulmonary Hypertension Association in the United States. Our little tagline, "Empowered by Hope," is one of my favorite things. There are many things about pulmonary hypertension, as you know, that are difficult, but we do find our power in the hope that we have and the work that we do together. So PHA is a little bit unique in that we work both with the general public and with medical professionals. So we have a tremendous amount of support for patients, caregivers, bereaved family members, allied health, which would be your nurses, your respiratory therapists, maybe your cardiac rehab folks, and then, of course, our wonderful doctors as well. It's been a big year at PHA after a couple of years of very hard work. We have a wonderful new website, which we hope is a great resource for you all seeking information. Same URL if you've ever visited us before, phassociation.org. But it should be very user-friendly, very mobile responsive, lots of updated and cleaned up information that you can explore. Things like living with pulmonary hypertension, not just your medication and what you do in the clinic, but the time in between that. So diet, exercise, social supports. Lots of caregiver resources, both for adult caregivers and for pediatric. We have a robust medical education program, and medical professionals can access our continuing education. We also have a certification in pulmonary hypertension for nursing, which is somewhat new. And if you are stateside and you want to get involved, there are a lot of ways to do that. I'll be touching on that in a little bit. But everything from attending to leading support groups to being on our telephone support line to working with our local, state, and national governments to work on healthcare reform and laws that help patients with pulmonary hypertension and also rare and chronic diseases in general. So this is just the shot of our homepage. You're greeted by a nice variety of smiling individuals, and it's very, very easy to navigate. So if you look up at the top, you can learn all about the different types of pulmonary hypertension. Then you have your tips for living with PH, events and resources. As far as events go, we do have our international conference happening in Texas this coming June of 2026, and you'll always have a very robust international platform for you all to network with your friends from around the world, learn what other associations are doing, learn what PHA can do to help support. And so we would absolutely love to welcome you in June. And again, that's getting involved, stuff for PH professionals, and ongoing news. One thing that we do have that we're hoping that you all can take a look at is all of the international pulmonary hypertension associations that are around the world. And if you see on here that your location is either missing or needs updating, we would love to hear from you. So when you go and look at the international associations, there will be a little add or update your organization. We'd love to know that you are there and working in your area to help PH patients and to support them and their families. So please do feel free to contact us through that button and let us know what you are up to. I'm going to give you just a minute to look at this map. There's a lot going on, multiple associations in different areas, but you can see we're covered Canada to Mexico, down to the global south, quite a bit in South America, lots and lots of activity in Europe, a little bit in Africa, and then we've got China, Japan, New Zealand. So again, if you don't see yourself represented there, we just need to know, and you can reach out and we can have you added. All right, one of the projects that I have been working on since it was a brilliant idea from some of our leadership right up through today is our PH care centers. And so these are essentially our centers of excellence. I'm very, very proud of this program and really thrilled with the level of care that patients are getting and the research that is coming out of it. So I wanted to share a little bit about that with you today. So our PH care centers are there to provide easier access to comprehensive PH care. The word comprehensive refers not just to the pulmonary hypertension care, but also hopefully a holistic team, or at least referrals that can get you into things like nutritional support, mental health support, exercise support. Although it is our heart and lungs, that are impacted by pulmonary hypertension. It's our whole body that has to walk around with it. And so it's really important that you're taking care of yourself from head to toe. And so one of the things we look at with care centers is that they have those resources in place for patients to look at outside of their time in clinic. They are also helping people get diagnosed earlier and improving long-term health outcomes. We're working hard to ensure treatments and medications are appropriately used to improve quality of life. You heard quite a few great examples in the last presentation of what that might look like. Unfortunately, when patients are seen outside of a PH care center or not with a pulmonary hypertension care expert, we do find that, medications can be described inappropriately. Patients might not be treated aggressively enough. It's really important that patients see a true expert in PH, and these care centers ensure that those professionals have been highly vetted and designated as such. We are working hard to give people with PH clear, reliable information about their condition and care options, and continue to support a medical community that's very well informed about PH standards of care, and offering more opportunities for patients to participate in PH research. So, with that, part of our comprehensive care center is the FAR program. So, this is the Pulmonary Hypertension Association Registry. And again, a little map for you to look at. This is something that our care centers can opt into. And when they do, they're able to enroll patients who qualify into the FAR, into the registry. And this allows us to collect data on treatment, how patients are doing, treatment changes, time to clinical worsening. It's just a huge resource for our researchers and for companies looking to create better and more accessible medications for pulmonary hypertension. So as you can see, the centers that have opted into the FAR program are spread quite nicely across the United States. And we definitely have a few areas of the US where we would like to maybe see more. But some of those blanks on that map are areas that are very rural and might not have a center or even that many people. Whereas you can see we're very congested on the East Coast and there are a lot of people who live there. So some of that is reflected here. All right, so this is so exciting for me to see because, as I said, being involved with this program from the very, very beginning when it was just kind of a dream, we now have 108 total centers of comprehensive care. So these are generally your very large hospitals. Maybe they're teaching hospitals associated with the university in a major city. These are care centers that see a lot of patients that are involved in clinical trial research, and quite a few other standards. And then we have 26 adult regional clinical programs that have been certified to date. These are smaller centers. Maybe they are not doing transplant, or maybe they do less with patients on IV, or they don't have a staff that's big enough to do real robust research, but they are still offering excellent top of the line clinical care to PH patients. And so they also can be certified as programs within our network. We are very excited to have 11 pediatric comprehensive care centers. As you might know, treatment for pediatrics offers a unique set of challenges. Children are not just tiny adults who can be treated the same way. Most of our medications are not approved for them, so they're either being treated off label or on a more select number of treatments. And then we also have 3 pediatric RCPs, so a total of 14 centers that are offering absolute top of the line, highly vetted care for our children. Of these PHCCs, 80 of them out of the 108 have opted in to participate in the FAR, and that has resulted in a number that just makes me so happy to see. We now have over 4,000 patients enrolled in the PH registry, and that is just a tremendous amount of data that can help improve quality of care, drive research questions, just look at ways to make a much better world for those of us living with pulmonary hypertension. And then here's another chart that I am very excited to look at. So this is courtesy of Kevin Hayen, who is our Vice President of Development at the PH Association. He let me know he was working on this, and I said, hey, can I borrow that, please, for my presentation? This is what's coming up. So you heard already earlier today what tremendous research and results we're having, but we still have a ways to go. We still have patients who are on very complex, very burdensome medications. The drugs that have hit the market in the last couple of years are just tremendous advances, but they don't work for everyone, or they're not for every type of pulmonary hypertension. And so while we're in a really great place in this disease state, we're still looking for innovation. So we have identified 10 companies that have something in preclinical trial status. We have 4 in phase 1. We have 18 in phase 2, meaning we're getting closer. And then 9 in phase 3, which is the final phase of clinical trials before FDA approval is a possibility. And so we're very hopeful. Some of these will not make it all the way to the finish line, but some of them most likely will. And in the coming years, to go from preclinical to phase 3 could take 10 years or more, but in the coming years, we should continue to see some really great innovation in treatment. So I hope that this bar graph is exciting for you to look at like it is for me. The other thing I really like to see on this, so these numbers in blue are group 1, kind of the more common form of PAH. Group 2 and 3 being more complex to treat and having a lot less treatment. I'm really thrilled to see these green and orange bars starting to go up as we look to offer hope to all PH patients with all sorts of types of PH. So, being mindful that this is a very international audience, I just want to go over quickly some of the barriers to care that we are facing in the United States. Because as wonderful as our progress has been, we certainly have our set of challenges. So, our barriers to care are paying for the medication, navigating our US insurance system, and spending just a very large amount of time on the phone advocating for our right to access care. And it is very burdensome on PH patients here in the States and very, very hard to navigate. So we go at this at 2 ways. We do a lot of national advocacy. So that's working in Washington, D.C. and contacting our reps who represent us at the federal or the national level. We will be doing a big Hill Day visit. So it's Capitol Hill, a Hill Day visit in March where many of us will go through a training. We'll go in with very specific asks for legislation that we're looking at that we hope will improve the lives of pulmonary hypertension patients. We rarely get to meet with the representatives themselves. They're very, very busy, but they have legislative aides who specialize in healthcare who sit down with us, are always very kind, very receptive. It's something that we can talk about with members who are of all different political takes and try to move the needle forward on the federal level. That being said, things do not move quickly nationally. So especially for me personally, and I know a lot of us, we also look to make changes at the state level. States are a lot smaller. It's easier to get directly in front of your representatives. A lot of times we are able to move things forward state by state, and then at the national level, the federal government will start to take notice. So as the notes say here, it is easier to leverage change at the state level. That's certainly something I've experienced. I've been able to help pass legislation and serve on a rare disease advisory council for my state, and see real change happen within a year or two instead of 5 or 10 years or 1 or 2 presidential administrations. One of the things we really want to focus on is that even when we can change policy, we have to make sure that society and values change with it. So the things that are important to us, like healthcare being a right for everyone, is something that people need to buy in no matter what the law is. And just a little reminder to my American friends that these are representatives who work for us, and we can always see them when they're at their home offices. and make appointments or go to their town halls and get in front of them. They are our employees. We put them there. We can vote them out. And so having an open line of communication with them about what's important to us as voters and as people who live in the areas that they represent is something that I hope everyone considers taking advantage of, and that you can do through the Pulmonary Hypertension Association with a great deal of support. We do have a lot of challenges going on in the US right now. We had major legislation passed called the Big Beautiful Bill. It is impacting insurance coverage in the United States, both Medicare, which is insurance that people get who are older or on disability, and also the cost of medication in the United States, which was also already very expensive, is getting much more expensive. So we are concerned about patients having enough coverage to access their care. Vertical integration in monopolies refers to the larger the companies get and the more things they do in healthcare, the more consolidated power they have, and the less options and leverage that patients have. We do have something called fail first or step therapy that we're looking to address, meaning that these insurance companies can deny a medication or push you towards a medication that is their preference, not your preference or the preference of the medical professional, the doctor who knows and treats you. We have pharmacy benefits managers, that's PBMs. They're kind of the middleman in our insurance system. They negotiate drug prices, but they also pass on potential savings to corporations and not to patients and get in the way of approval of medications. They are very, very challenging to work with quite often. And that prior authorization means that if your doctor prescribes a medication that they know is best for you, the insurance company can come back and make them do hours of paperwork and appeals trying to get you the medication that your doctor already thinks is best. We are having a lot of challenges with oxygen coverage and reimbursement. Patients, unfortunately, are having a really hard time getting enough oxygen delivered to them that they can be independent and out and about. We are seeing patients ration oxygen, allowing their saturations to go lower than is safe, staying home for 3 or 4 days so they have enough oxygen to take with them to, let's say, their nephew's birthday party. And this really has to do with the way oxygen is paid for and covered, and we need changes in that. And then we do have outside organizations, the Institute for Clinical and Economic Review, ICER, and drug pricing review boards that are chiming in on what a medication is valued at and how maybe it should be covered or not. And their numbers and their outlook don't always meld well with what is best for PH patients and the reality of the cost of care of pulmonary hypertension. And so when they put out their opinions and insurance companies try to take them into account, we sometimes have to work on that so that it is more friendly for patients. So lots and lots to celebrate, lots and lots to work on. We've had a really exciting year in 2025. We're looking forward to continuing our efforts to improve pulmonary hypertension care for patients, not only in the United States, but all over the world in 2026. So I'm going to stop my share there.
Great. Thank you, Colleen.
All
Yeah, a lot
right.
to celebrate indeed. The new website is looking amazing. I just had a quick glance at it while you were talking and shared the link in
Looks
the
great.
chat. So I encourage people to look at that. And we did have a question from Melanie. She's curious to know if you have any idea of if pediatric patients mostly have congenital heart defects associated to PAH. Apart from that category and idiopathic PAH, are there many other diseases among pediatric patients?
That's a great question. I am definitely not an expert in the pediatric area. I see someone responded with what is happening in the Netherlands, 50% due to congenital and 50% PAH, with a small percentage being heritable. I would say we see a mix like that. You'd certainly do hear of a lot of children who have PH due to congenital heart diseases or heart defects. I do not have solid data on that. Sorry.
No problem. Thanks very much. And
Mhm.
no, thank you, Colleen, for your support of the Alliance this year, including doing a great pep talk that's on the Alliance's YouTube channel and in the knowledge sharing platform under the pep talks. You can hear more of Colleen there. And yeah, we just really appreciate all of your support of the Alliance and updating us on what's happening in the United States. Certainly been quite a year of ups and downs.
Indeed.
So yeah, with that, I'd like to call our next speaker up, Dina Grajales from the Latin Society for PH. Dina, come on camera when you're ready. Thank you. And Dina is going to be speaking in Spanish today. So it's very important at this stage, if you haven't before, to click the link that I put in the chat. At the beginning, I put in the wrong link. Sorry about that. Luckily, Dina helped me to realize that. So this is the correct link. Click on that, select your language. And then, you can either read along as Dina speaks and have captions in that web browser, or you could even hear a voice to be played if you'd like. And then in that case, you want to lower the volume or mute the Zoom temporarily. So just give people a second to do that. Click that link, select your language. And of course, let me know via the chat or a private message if you're having any trouble, but hopefully everyone can do that. And yeah, with that, Dina, yo creo que podemos empezar. Adelante. Muchísimas gracias. Thanks for joining us.
Buenas tardes para todos. Muchas gracias. Ya voy compartiendo mi presentación. Ok.
Sí,
Bueno,
ya podemos
buenas
ver.
tardes. Perfecto. Buenas tardes para todos. Agradezco muchísimo la invitación a la Alianza Mundial de Hipertensión Pulmonar. Como ya me han presentado, soy Dina Grajales, vivo en la ciudad de Bogotá, Colombia, y estoy en nombre de la Sociedad Latina de Hipertensión Pulmonar, que es una organización regional creada hace más de 20 años, primera en la región, donde se encarga de impulsar el apoyo para que se crearan las primeras organizaciones en cada país de Latinoamérica. Este es nuestro grupo. Somos una organización reconocida internacionalmente por dar respuestas a necesidades de colectivo de hipertensión pulmonar en la región, dirigida por profesionales, en su mayoría pacientes y representantes de varios países latinoamericanos. Yo recibo el diagnóstico de hipertensión pulmonar hace 21 años. Caminé muchos años sola, sin conocer ningún tipo de organización, hasta que conozco el primer grupo de pacientes en Colombia. Nace la primera organización y conozco de la Sociedad Latina de Hipertensión Pulmonar, donde me uní inicialmente como voluntaria, después como vocera y actualmente como presidente de la junta directiva. Acá pueden conocer la junta directiva. Todas somos pacientes y tenemos un miembro asesor, también paciente, cada una representando un diferente país de la región latinoamericana, que permite tener las diferentes realidades que se viven, porque el hecho de ser una sola región no significa que todos los países deban vivir la misma realidad en cuanto es la vida del paciente con hipertensión pulmonar. Estas son las organizaciones que hacen parte de los 19 organizaciones actuales. Tenemos en Colombia, Venezuela, Costa Rica, Panamá, Bolivia, Chile, Perú, Uruguay, México, Argentina, Ecuador, Perú, Guatemala, Salvador y Colombia. Nuestros aliados estratégicos, Latin Health Leaders, la Global de Enfermedades Respiratorias y la Europa Lung Foundation. Nuestras realidades específicas en la atención para la hipertensión pulmonar. Bueno, sigue siendo una enfermedad con una carga y mortalidad. Nos hemos guiado en Latinoamérica desde estudios globales recientes que siguen mostrando un impacto importante en los años de vida y la necesidad de un mejor diagnóstico. En Latinoamérica se estima que existen 15.116 personas con hipertensión pulmonar del grupo 1, pero esta estimación también de muertes anuales por hipertensión pulmonar en la TAM está aproximada en 1.790 personas atribuibles al grupo 1, usando tasas de 2021 como referencia. Quiero aclarar que estas cifras no son confirmadas, sino que son estimadas con bases en estadísticas de manera global. La investigación sobre la hipertensión pulmonar en países como Brasil, Argentina, México y Colombia muestra un aumento en diagnósticos, pero sigue siendo una enfermedad con baja visibilidad en muchas de las áreas, lo que limita estudios epidemiológicos amplios. No hay datos exactos y completos publicados para 2025 que indiquen un número definitivo y consolidado de los pacientes en toda la TAM, debido justamente a esta falta de registros epidemiológicos poblacionales amplios y centralizados en la región. Sin embargo, hay unas estimaciones basadas en estudios, en registros parciales y datos extrapolados que permiten aproximar la magnitud de la enfermedad en la TAM. Actualmente, el grupo de Argentina, el grupo de Colombia, el grupo de Brasil y el grupo de México han hecho diferentes estudios donde arrojan algunas cifras, pero no hay ninguna data complementada de la región. Este resumen de cifras aproximadas para Latinoamérica, donde podemos ver que la prevalencia aproximada para hipertensión pulmonar en los adultos es de 22 a 25 casos por millón de habitantes, estimado de manera global, siempre tomándolo como referencia. Pero también tenemos una estimación de paciente con hipertensión pulmonar de 4.000 a 15.000 casos, estimación basada en registros regionales independientes. Nuevos casos por año de 700 a 4.600, nuevos diagnósticos estimados anualmente según datos registrados locales. Y acá todavía hay un trabajo demasiado fuerte porque a veces llegan a las organizaciones locales que están en 14 países de la región, nuestras organizaciones, llegan pacientes ya hospitalizados en UCI, cuando días después de haber contactado a la sociedad latina o a la organización local fallecen. Entonces, tenemos un grave problema todavía con que el diagnóstico sea a tiempo, con que el hecho de que no haya profesionales que conocen de la enfermedad hace que muchos pacientes no reciban ningún tipo de diagnóstico y fallecen antes de recibirlo. La atención en la región no es uniforme, está fragmentada, inclusive al interior de cada país latinoamericano hay fragmentación de acuerdo a los sistemas de salud a los que pertenecen también los pacientes. Hay centros con capacidad diagnóstica y otros con grandes brechas, ya que una cosa son los centros de referencia, otros son clínicas o hospitales donde existen médicos que conocen de la enfermedad, pero no están organizados como un centro. La falta de la familiaridad con la hipertensión pulmonar, desde la medicina del primer nivel hasta el intermedio, hasta el especialista, sigue siendo una barrera principal. Los retrasos desde los síntomas hasta la atención especializada. Algunos médicos todavía confunden los síntomas con obesidad, con fatiga, con ansiedad, lo que retrasa los diagnósticos, y las barreras geográficas, económicas y burocráticas impiden el acceso continuo y atención a medicamentos. En Latinoamérica, la parte geográfica también es supremamente incidente en el pronóstico del paciente. Todavía tenemos poblaciones alejadas que viven en sector rural, en zona selvática, o también los tenemos que todavía cocinan con humo, con leña, o en partes donde no llegan los cuerpos médicos. Entonces tenemos una fragmentación geográficamente que tampoco ayuda mucho a que toda la población en general del país pueda acceder a un servicio de salud. Esfuerzos de educación y redes regionales, las series de webinars educativos sobre diagnósticos a médicos de Latinoamérica es uno de los esfuerzos grandes que hemos podido hacer de la mano de la sociedad científica como es ALAD, PBR y LATAM, y las sociedades científicas locales de cada país de Latinoamérica. ¿Por qué este punto es tan importante? Porque necesitamos llegar a esos médicos que todavía no se han especializado en hipertensión pulmonar, que están definiendo especializaciones y que necesitamos más médicos que traten la enfermedad. Los simposios latinoamericanos siguen construyendo conocimiento, pero todos los médicos a veces no pueden desplazarse a estos congresos internacionales. Es por eso que desde la sociedad latina, desde las organizaciones locales, impulsamos también que la educación a los médicos sea dentro de cada país latinoamericano. En este último evento que tuvimos la oportunidad con la sociedad latina, tuvimos la 10ª cumbre de líderes de organizaciones de pacientes de hipertensión pulmonar. Ocurrió en el mes de septiembre, donde pudimos certificar desde la sociedad latina a 32 líderes y representantes de organizaciones de Latinoamérica en hipertensión pulmonar. Todo esto fue en el marco de un congreso científico de la Sociedad de Neumología en Colombia, donde también se pudieron actualizar en cómo iba la hipertensión pulmonar directamente desde los profesionales. Pudimos también aprender de liderazgo, de defensa de los derechos de los pacientes y trabajar también en que el líder en grandes oportunidades, en el 95% de nuestra sociedad, son pacientes. Entonces, es trabajar un todo, no solamente por ser hipertensión pulmonar, pulmón, corazón, sino tratar de trabajar al paciente, al cuidador, al líder en toda la actualización lo referente a la hipertensión pulmonar. Avances terapéuticos. A nivel global, sabemos que hay terapias innovadoras en etapas muy avanzadas y aunque el acceso en la TAM sigue siendo limitado por costos, por sistemas de cobertura insuficiente, inclusive por barreras dentro de los mismos sistemas de salud, desconociendo la comunidad de hipertensión pulmonar para sí mismo negarles el acceso. Por ejemplo, tenemos un ejemplo con México, que fue el estudio RMI, donde identifica brechas en diagnóstico y acceso a tratamiento, incluso cuando las guías terapéuticas existen. Estos avances representan un nuevo enfoque y esperanza, pero por ahora no están universalmente disponibles en todos los sistemas de salud de Latinoamérica. También tenemos los altos costos de medicamentos especializados dificultan la atención efectiva en países de ingresos medios o bajos. En Perú, por ejemplo, solamente el 20% de los pacientes con hipertensión pulmonar recibe una cobertura estatal de tratamientos y el resto queda excluido. En México, menos del 1% de los pacientes recibe un tratamiento adecuado, pese a estimarse varios miles de casos. En Colombia, por ejemplo, el tiempo estimado para que el paciente llegue a un centro de referencia es de 2 a 3 años. Escasez de especialistas y sistemas de referencia. La formación específica y los centros de referencia son claves, pero no se cumple a totalidad. Las asociaciones de pacientes en Latinoamérica reportan la falta de especialistas y sistemas de referencia bien establecidos, especialmente fuera de las capitales. En Chile, por ejemplo, actualmente la discusión se destaca en la atención de calidad y en la seguridad y eficacia de fármacos que de verdad ayuden al paciente y no lo pongan en riesgo. Algunos testimonios de pacientes y comunidades cuando tocamos el tema de escasez de especialistas, de centros de referencia, nos dicen, nunca me explicaron qué significaba realmente mi diagnóstico. A veces ni siquiera los médicos lo comprenden. Tuve que viajar a otra ciudad para confirmar con cateterismo. Las salas de hemodinamia tampoco son accesibles a todo tipo de poblaciones. Los medicamentos caros no están cubiertos en mi seguro. Ese es un problema también que tenemos en varios países de la región. Brechas entre aprobación y acceso real. La aprobación no significa que estén disponibles en todos los sistemas de salud. Algunos países aprueban, pero se demoran muchos años para que el primer paciente pueda acceder al tratamiento. Los países de bajos y medianos ingresos enfrentan las barreras como el registro nacional, los precios, inclusión inclusive en las listas oficiales. El caso del sotatercept, que es la última terapia innovadora de la que se habla, en algunos países es ejemplo de llegada regulatoria, pero no equitativa. El diagnóstico tardío, hablando de las barreras y el diagnóstico, las rutas fragmentadas, la falta de pruebas confirmatorias, el subdiagnóstico, el desconocimiento clínico, los pocos especialistas, registros como el de México, Colombia, muestran viabilidad y deficiencias en atención estructurada. La salud mental y la migración a causa de las barreras anteriormente mencionadas, justamente por falta de acceso a tratamientos y oportunidad de seguir viviendo, es una alta realidad de Latinoamérica que va unida también a la parte gubernamental y social que experimentan muchos de nuestros países. Escasez y disponibilidad de terapias en Latam. Países como Bolivia, Ecuador, Panamá y El Salvador cuentan con 2 terapias orales que no se hace efectiva la mayor parte del año. Teprostinil subcutáneo, disponible en Argentina, Colombia, Chile, México, Costa Rica y recientemente en Uruguay y Perú. Nicaragua, Honduras y Cuba, solo con un tratamiento no cubierto, y el caso del sotatercept en Latam, aprobado solamente en Argentina. Colombia y México los tuvieron como estudios clínicos, pero ya cerrados, eh, y en este momento contamos con otros ensayos clínicos, pero en los mismos países. Argentina, Colombia, México, Chile y a veces Brasil tienen en este momento entre 5 y 6 ensayos clínicos. Impacto socioeconómico para los pacientes, los costos de tratamientos, el transporte, los tiempos de cuidados, la incapacidad que genera la condición en personas jóvenes y no logran a veces tener el medio de sustentarse, el alto costo de las terapias donde nunca las van a poder acceder a ellas. Ahora, ¿qué ha avanzado para 2025? Bueno, son mayores esfuerzos, eventos como el que estamos presenciando hoy, nosotros hablando desde Latinoamérica para Europa y para la parte global. Sin duda, estos son unos esfuerzos muy grandes de concientización, donde se pone en foco y en lupa la situación de Latinoamérica, generar redes académicas y eventos. Desde la sociedad latina hemos tenido la oportunidad de estar en el Task Force del Simposio Mundial de Barcelona, PBRI Latam, también en el Mundial, y todo esto también hace que las redes de organizaciones puedan tener un relacionamiento mucho más definitivo con las organizaciones científicas y con la industria farmacéutica. Un problema que tenemos en Latam es que en nuestros países pequeños los ensayos clínicos no llegan, no ingresan, y allí también vemos una inequidad, porque así seamos pocos, merecemos también tener acceso a la investigación. Los ensayos clínicos son una oportunidad de tratamiento. Recomendaciones prácticas, redes de referencia y telemedicina para descentralizar la atención cuando las personas se encuentran en extremas lejanías. Capacitación médica focalizada para los médicos desde el primer nivel y especialistas actualizados. Acceso equitativo a medicamentos innovadores con estrategias como negociación de precios, programas de acceso temprano, registros nacionales, pero también latinoamericanos, con datos sólidos para visibilizar estas necesidades que estamos conversando, y alianzas entre todos los sectores, las organizaciones de pacientes, gobierno, sociedad civil, sociedad científica para unas políticas más estructurales. Ahora, como parte del llamado a la acción, todos estos avances 2025-26 todavía tenemos en deuda, todavía eh, tiene una alta mortalidad en Latinoamérica, tiene pérdida de calidad de vida, tiene incapacidades eh, irreversibles para los pacientes. Tener la campaña regional con el mapeo de los centros de diagnóstico, el acceso a terapias por país, registros de pacientes, seguir educando y empoderando a las familias, educación continua a los médicos para que se sigan especializando, incidir en políticas públicas con cifras de la región de una manera local ante tomadores de decisión. Y tenemos en este llamado a la acción 2026 la plataforma pulmonesvitales.com, que como pueden ver tenemos a Aura, que es un asistente virtual, el cual tendrá una experiencia para la navegación de los pacientes en cada país de la región latinoamericana. Se ofrece una ruta educativa con un acompañamiento fase por fase del reconocimiento, síntomas, incluye materiales prácticos, videos, proporciona foros activos, interacciones. Tenemos charlas con médicos especialistas donde los pacientes podrán contactar a los doctores de la región, el doctor de Argentina, el doctor de Colombia, el doctor de Perú. Y algo muy importante, en esta plataforma tenemos un directorio de los médicos por cada país de Latinoamérica, donde el paciente desde que inicie su camino no se va a sentir perdido porque va a tener toda la información a dónde están ubicados los doctores. Esta fomenta una comunidad de apoyo, se reduce aislamiento y empoderando a pacientes y cuidadores. Estas son algunas de la perspectiva de nuestra página Pulmones Vitales, el toolkit digital de pacientes de hipertensión pulmonar, el toolkit del Latin Health Leaders con el apoyo y respaldo de las organizaciones de la Sociedad Latina de Hipertensión Pulmonar. Acá tenemos los primeros pasos, cuidarme, aprender, superar. Tenemos bienestar, confianza, tenemos los directorios exclusivos y también actualmente tenemos la encuesta latinoamericana de pacientes con hipertensión pulmonar disponible dentro de Pulmones Vitales, donde se recoge la perspectiva de los pacientes de la región verificada y es con el respaldo de los médicos referentes de hipertensión pulmonar en la región. Datos importantes, seguir trabajando por estadísticas, bases de datos cualitativas, abogar y defender a los pacientes, promover capacitación a los médicos y el empoderamiento de las familias. Nuestra estrategia digital ha tenido gran alcance. Hemos podido llegar a pacientes en toda la región latinoamericana, inclusive a pacientes de habla hispana que viven en otros continentes, con diferentes actividades que realizamos, hablando de hipertensión pulmonar y de cómo se puede vivir mejor cada día. Muchísimas gracias y Sociedad Latina respirando juntos por un mismo fin.
Muchísimas gracias, Tina. Y tenemos algunas preguntas. Luis pregunta, ¿cómo podemos ayudar pacientes en América Latina que no tienen acceso a la medicación o cuidado adecuado? ¿Hay algo que podemos hacer a mejorar esta situación? Queremos, pero no sabemos cómo.
Bueno, es una pregunta excelente, excelente, porque siempre Latinoamérica trata de buscar el ejemplo europeo o norteamericano para saber cómo se trata la hipertensión pulmonar allá. Entonces, actualmente pasa, por ejemplo, Venezuela. Venezuela hace muchos años tuvo todas las terapias para hipertensión pulmonar. Actualmente, debido a la crisis que no es un secreto para nadie, ellos tienen uno o dos medicamentos una vez al año, no tienen el resto del tiempo. ¿Cómo subsisten? De donaciones internacionales o a veces de pacientes que han fallecido y donan las familias, ¿sí? Entonces, cada país de Latinoamérica tiene una diferencia de las barreras de acceso Y lo importante es que ya la mayoría de las personas que están en esta reunión, muchos me conocen, tienen el contacto con la Sociedad Latina de Hipertensión Pulmonar. Nosotros podemos ponerlos en contacto con la organización de cada país. Podemos hacer una reunión con cada país. Nosotros tenemos definidas las necesidades de cada uno de los países. Claramente, la mayor dificultad es el acceso al medicamento, es la mayor, es uno de varios. Pero sabemos nosotros, la mayoría somos pacientes con hipertensión pulmonar, y es que sin el tratamiento, la vida se acorta, la vida se acaba. Entonces, creo que por ahí podemos empezar. También voy a dejar mi correo electrónico de la Sociedad Latina en el chat y pueden contactar conmigo porque nosotros tenemos a todas las organizaciones de la Sociedad Latina felices de poder aprender y compartir también con los otros continentes.
Muchísimas gracias, Tina, por tu presentación y por todo tu apoyo este año. Nos agradezco mucho. We really appreciate you. Thanks very much, Tina. With
Gracias.
that, we're going to go to our next speaker, who is Noriko from Japan. And just give me a second here to change the audio. Please, if you can't hear correctly, please put a note in the chat that it's not working. But otherwise, here we go.
Hello everyone. My name is Noriko Murakami. I'm going to tell you a bit about what is happening in PH field in Japan. PHA Japan is founded in 1999 and the only national PH patient association in Japan. Our mission is to support pulmonary hypertension patients and their family members to cope with the disease and improve patients' quality of life. Our goals are to have PH patients and their family members understand PH, cope with PH, and to improve and develop healthcare and a social environment that will enable PH patients and their family members fight with PH without undue concerns. To raise social awareness is also very, very important for us. Places we act are in Sapporo, Tokyo, Osaka, and Fukuoka. Our national activities are as follows: hold networking and study meetings, organize national PH conference every year, operate PHA Japan website, issue newsletters, cooperate with and submit requests to regulatory authorities to improve, enhance research, healthcare, and welfare systems for incurable diseases, and raise awareness of early diagnosis and treatment. Our international activities, such as collaboration with overseas patient groups and exchange information, are also very, very important for us. Our latest activity is to create a collaborative project on survey on pulmonary hypertension, clinical situation, and patient quality of life in Japan with Japanese Circulation Association and the pharmaceutical company. Now I would like to introduce members of our Medical Support Council. We have 15 doctors as our Medical Support Council. The board members in each area work together with the members of our Medical Support Council. Next is treatment in Japan. We have 12 drugs, including sotatercept, approved, and all medications are covered by our national health insurance in Japan. Therefore, patient pays very, very little money for their treatments. Apart from drugs, transplantation and BPA and PTE are also available, covered by our national health insurance. What are the biggest unmet needs in Japan? We presented last year a joint survey conducted by PHA Japan, the Japan Heart Disease Association, and the pharmaceutical company on the current situation of PH patients in Japan. The survey revealed several issues, including a significant decline in school and work participation rate and the communication rate between patient and doctors for treatment goals. What are our top priorities for the next year? Our top priorities for the next year will be empowering patient voices. In East Asia, many patients hesitate to speak up to physicians. For this, Asian hierarchical communication culture makes shared decision-making very difficult. However, shared decision-making is essential for patients to make informed choices and to live their own lives with PH. So, we are planning to publish lay summary in next spring, working together with Dr. Tamura, who was the leader of 2025 Japan PH Guideline Task Force. We hope this lay summary will help both patient and physicians, enabling shared understanding each other. We plan to organize East Asian PH Conference in May next year, where PH patients, groups in East Asia, such as Japan, Korea, and Taiwan, will discuss shared decision-making and patient empowerment together. We hope this cross-country learning and regional collaboration will help us to build the next chapter of PH care in Asia. Well, these are all for now. Thank you. ありがとう。
Okay, thank you very much, Noriko, for that. Yeah, very nice overview and good to see what's happening in Japan. Our friend Gergely Mesaros will be coming up next for our next presentation about what happened in Eastern Europe in 2025. Thank you, Gergely. Take it away.
Thank you, Robert, and many thanks for inviting me for this webinar. Actually, I tried to address these questions regarding Central and Eastern Europe. We already have a nice global walk around each and all main parts of the world, but currently there is growing interest towards Central and Eastern Europe. So I think it's really high time to talk a little bit about these countries, what's really happening in this region. Earlier this year, I was asked to participate in a patient academy, and we tried to elaborate kind of challenges which patient organizations are facing. Probably many of you might experience these difficulties I put on this slide, but I tried to put from a different angle, from the Central European patient perspective angle, which is based on some interviews I already have within the region. So main topic is the funding. As you might know, there are not many pharmaceutical companies which are registered or based in Central Europe. So it's very difficult for these patient organizations to have a sustainable long-term financing, which is essential for having, for instance, an office or long run projects. Another problem, which is actually a big problem for Central Eastern Europe patient organizations, is the critics on independence and reliance. I think many of you might have read articles from the United Kingdom where patient organizations are considered as the long arm of various pharmaceutical companies because they are advocating for earlier diagnosis, which might generate more selling of the pharmaceutical products or using more medical devices. But for instance, in Central and Eastern Europe, it's another type of dependence we experience. What I'm talking about is that the linkage to physicians. Actually, we already experienced some of the patient organization, and it's related to pulmonary hypertension. The vice president or even the president is a physician, which is quite strange if we take into account the very definition of the European Medicines Agency of patient organization, which should be patient-led. And probably you might also recall that within the World Symposium proceedings, we also relied on the European Medicines Agency definition. However, we also provided additional recommendations. So it's quite strange. I also heard from the Eastern European PH organizations that they are so linked to one of these top centers that actually the leading physician asked the president or the vice president not to contact the countryside expert centers in order to enroll more patients in the patient organizations. So I think it's critical and it should be addressed. Stability. Sadly, we experience from the pulmonary fibrosis community that the leader passed away as a result of COVID. And what we saw that the whole organization collapsed. So we needed to rebuild all the connections to pharmaceutical companies as well as to the patient community, because usually it is the case that charismatic people gathering and collecting all the help or the patient community. And once we have this main person out, we experience this problem. So it should be a kind of approach and in each and all patient organization to build a kind of internal structure in order to replace if someone is having difficulties, for instance, as a result of his or her disease, having other type of commitments which does not allow for him or her to push more and devote more time to the patient organization. I think professionalism might be also something important to be addressed, especially in Eastern European countries, where you might know lots of EU statistics that many patients do not speak foreign languages, which actually a difficulty when it comes to cross-border advocacy. And last but not least, these two lines is about how patient organization tasks are outsourced. I think it's also you can experience in other countries, not specifically in Central Eastern Europe, that some of the pharmaceutical companies are issuing their own specific leaflets and handouts, which should actually be the task of patient organization, collecting many aspects as well as many opinions from various pharmaceutical companies. It is especially difficult in Eastern European countries where they lack a little bit of resources, as I already mentioned. So they need to rely on these papers, these materials. And last but not least, we experienced in Eastern European countries that some of the activities, which usually should be within the healthcare system, like psychosocial support and so on, actually it is delivered by patient organization, putting extra burden on the shoulders of these relatively teeny organizations. But I would not like to be very pessimistic. So what kind of opportunities we have for these patient organizations? Sadly, there's no pulmonary hypertension representation in the health technology assessment. I will cover this a little bit later on, but I think it's a magic word and everybody is really talking about this. But pulmonary fibrosis is within the EU HTA stakeholder network, so there's probably there might be some collaboration on this. Research might be also something which Pulmonary Hypertension Association within the CE region might be interested or involved. We see increasing interest towards, for instance, Baltic countries. Gossamer Bio with their drug, they managed to onboard many patients from the Baltic countries, so for seralutinib. And we also see that, for instance, PH-ILD trials are or might be happening in some of the CE region. Luckily, there are many ongoing trials, so pharmaceutical companies have more interest towards CE region, onboarding those patients who are not enrolled in other clinical trials, which might be exclusion criteria for other clinical trials. Collaboration might be also interesting. I will cover this later on with HTA and participation in scientific world. I will show you some publications which might be really interesting for CE region patients. And sadly, you will not realize many patient co-authors in this, which is not really the case in Western European countries, where we usually see at least one or two co-authors, which are patients or patient representatives. Last but not least, advocacy. I think that it should be not covered at that point in more details. I will bring some real evidence and some examples, exact examples from some of the countries. But before we dive in the HTA words, I would like to say some words about ER and lung. Based on the participants, it seems that many of you might be familiar with this structure. But I think there might be two really important things which I can bring up. So in one word, ER and lung is a network of healthcare professionals. They are mainly expert centers, but we closely work together with patients. So in the heart, we have the patient board. There are many initiatives, the undiagnosed patient one, the Go East one. We have a very special registry for patients. So let me take this opportunity to promote our Breathe e-registry. So you as a patient or patient representative or carer or caregiver, you can input your own data without the help of any physicians, and with that we might have a better understanding of the patient population in each and all countries. And naturally, everybody is really interested in the patient journey. So together with ERS and the European Lung Foundation, ERS stands for European Respiratory Society, we build up a comprehensive patient journey. And already regarding CE region and related to ER and lung. One of them is the Go East project. I'm the one who is responsible this one. I leave you some minutes to have a closer look on this spreadsheet where you can see pH, how it is represented in Eastern Europe. And you can see there are many, many white spots. But luckily, since the launch of this program, we managed to have a pH center in Hungary. Also, we have two in Greece. I'm in a very long discussion with Barbara Salobir from Slovenia. Hopefully, they will submit their application so we can also go a little bit to the Balkans. And it's very difficult to build some bridges to Bulgaria. And last but not least, Romania might be also in our focus. Most recently, we managed to onboard a center from Timișoara, but they were not approved for pulmonary hypertension, but for other rare lung diseases like ILD, PCD. But I hope that because there's an ongoing discussion with one of the key opinion leaders from Bucharest, that there might be a pH center also in Romania. I think it's crucial because they already almost have 20 million inhabitants, and it's a pity that they are not part of this EU-wide collaboration. The other interesting one, and I just putting more emphasis on Romania, is the participation of the ER and Lung Academy. So 2 or 3 years ago, I was a great advocate in terms of having more and more applicants from Eastern European countries, and somehow we managed to break the wall because, as you might see, the top country in terms of the number of applicants is Romania, but also other Eastern European countries are well represented. This ER and Lung Academy is a great initiative because it provides a practical on-site stay for junior colleagues. So as we
think Gargly may have frozen. Can anyone put it in the chat if that's also the case for them? If it's just me, I apologize for interrupting. Okay, yeah, it's frozen. Thank you, Florine. All right. Love for him to be able to finish. So maybe we just wait a minute. Yeah, it looks like Gargly might have had a laptop problem. I had a daughter coming into the room problem. Yep. So yeah, we do have a few more minutes, but I don't want to close before maybe he comes back. Florine is making some great points about Romania. And I hope you can talk, connect with Gargly after this. Pisana, any thoughts? I sent him a message. Let's see if he comes back. Okay.
Let's give him
Happy
a
to
couple
do
more
that.
minutes.
Okay.
We
Thanks,
give him
Pisana.
a few more minutes. Would be a pity
Yeah.
to close without him.
Yeah.
So
Yeah,
we
and
very
without
interesting review already.
being able to finish his talk for the recording too. Would be a pity. Meanwhile, I hope everyone used the Wordly. I did see that most everyone that was connected had it switched on. It allows you to see that in the statistics. So thank you for following the instruction, and as a result, hopefully being able to follow Dina's excellent presentation about what's happening in Latin America.
I tried it, it worked perfectly. And the translation comes almost immediately. It's very efficient and very
Yeah,
precise. Yeah. Thank you,
yeah,
Dina,
you're very.
for
Thank you,
presentation.
Dina.
It's sad to hear how many challenges patients are facing still
Yeah.
in countries of the world, including so-called very developed ones.
Yeah, and it's sad when countries like Venezuela backslide, from being able to support people living with PH to, yeah, just a complete disaster there, I think, on every level.
Indeed, indeed. I think at this point it's unlikely that Gergely will join us. I'll see if he's replied to my message. No, he has not seen it even, so.
Okay, something may have gone very wrong. Well, then we'd like to thank you all for joining. As a reminder, the recordings and slides will be posted on the knowledge sharing platform hopefully this week.
He's here.
And
Okay.
great.
He asked to send him the Zoom link again. He's gonna.
Okay,
So we
he's
have a
gonna
few
come
more
back.
minutes. Yep.
Great. Yeah, yeah.
Send him the
I
link.
think. Hooray.
Okay.
Let's just see when he comes back to make him a co-host again. Laureen says we must make sure that we have an early diagnosis system in place as a matter of urgency if we're to reduce future costs. The second measure must be to raise awareness among medical staff. They must learn to identify PH in the early stages and implement the appropriate treatment ASAP or as soon as it's available. The financial aspect is undeniably the elephant in the room. The high cost of PH treatment per patient is simply unacceptable. Agree. Agree, however, don't have any solution here myself.
He wants the link in WhatsApp. Can you do that?
Will you want me to do that? I don't think I have Gergely on WhatsApp.
Find the link then.
Um, I can share the link with you.
It's okay, I've got it.
You got it? Okay.
Apologies. Can you hear me now?
Yes, Kegli, we hear you.
Sorry, I have difficulties with my internet, so I would like to rely on your help, Robert, with sharing the slides, if it is possible.
Yes,
Thank you, and
definitely.
apologies again. I just somehow...
No problem. Thank you for coming back. Do you know more or less which slide you left off on?
I think you should have heard about the ER Lung Academy.
Yeah. Yeah, that's right. Oops, where did the... Oh, I stopped this. Hold on 1 second, please, and then I'll get back to that. There we go. Okay.
Excellent. Many
Now,
thanks and apologies again for this. So I would not spend more time on this. So you can see that Eastern European countries are well represented, like Romania, Poland. We also have some representatives from Hungary and so on, and in Lithuania. I think it's a very nice step forward of being integral part of activities which are mainly driven by Western European countries. Next slide, please. And I already talked about a little bit HTA. So European Pulmonary Fibrosis Association is part of the HTA stakeholder network. And I think each and all patient organizations should be prepared for this, because as you can see, it will be a step-by-step coming into force. And in 2028, rare diseases will be in the scope. So currently we can learn a lot from oncology and advanced therapies. However, when I was talking with local HTA bodies, it's very clear that in Central Eastern European countries, mainly there's no contact towards patient organizations. And we see that many pharmaceutical drugs are in the pipeline, luckily. So it might be expected that going forward, the clinical assessment, which we call the joint clinical assessment, GCA, will be conducted in some of the PH drugs. So each and all patient organizations should be prepared and be contacted and be in contact with local HTA bodies. So in the right-hand side, you can see what will be the new structure. So there will be a centralized EU level assessment, but some of the tasks will be at member states level, like definition of population, comparators, and also reimbursement questions. And as we learned, if the local HTA bodies do not have exact connections to Pulmonary Hypertension Association, then they will connect big umbrella association. And for instance, I participate in the COPD World Day, and I was really surprised that, for instance, there's no COPD organization, patient organizations in CE region. So what they are having a look at, they are looking at bigger and more general patient organization like EPF on a European level, and probably they might not have the professionalism as well as the knowledge of pulmonary hypertension or other pulmonary diseases. So I think it is a crucial step that each and all patient organization should contact the local HTA bodies in order to be registered for this. Next slide, please. And why I was talking about a lot, because you might find it very difficult. Probably it's a little bit busy, but I copied it from a very current paper which was published in the pulmonary, I think it was a Polish Heart Journal, thanks to Gregor Kopec and others like Paweł Jansa from Prague. And it's a very nice comprehensive table, what kind of therapies are available or actually reimbursed in C region. I think it's a common practice not only in Central and Eastern Europe, but also in Western European countries, that mainly those drugs are available actually, which are reimbursed, because these drugs are very expensive. But you can see that many oral treatments are available in Central and Eastern European countries. However, epostenol and sotatercept are not available in most countries. You can also see that registries are missing in many countries, and I will go back to this once I will talk a little bit about country specific. Next slide, please. So I tried to collect lots of pieces of information regarding the reimbursement of sotatercept. I managed to get in contact with Merck, and they said that, okay, however, we might have some publications regarding
Uh-oh. I lost him again. Yeah, Dare says cut off. Thank you. Sorry, everyone. We may have to just schedule a makeup for this last presentation.
I'm back again.
Oh, back. Okay.
So
Please go ahead.
something
Sorry.
happening. Probably I'm talking too long, or it's not very interesting topic for you. Probably I will skip some of my slides. So apologies again for this. So you can see it's nicely balanced, and it's not always depending on the reimbursement, whether it's a huge market or not, or whether it's based in Central Europe or not. But I think it's might be interesting in the coming months. And some advocacy activities might be also needed, also in the HTA stuff, that some of the medication, I mean the sotatercept, should be available in other countries. Next slide, please. And probably you might be eager to learn more about some of the examples from Central Eastern European countries. So I try to build on some publicly available sources. I participate in some of the activities, and also there are some artificial intelligence research based on this. I think Bulgaria might be interesting from this topic. You might recall that even from the Go East project, it's a kind of a wide spot. There were many, many elections in the past in Bulgaria, so it's not a very stable healthcare system they are having. They are struggling with many, many personal changes. So probably it might be some of the reasons why it's not very established. So I think some of the numbers are shocking here. So if you see that 90% of the PH patients are class 3, it is a very important and shocking indicator that there's no early diagnosis of PH in Bulgaria. But there are also follow-up challenges, as you can see, that many, many patients are lost. Probably it might be the case that some of the patients are misdiagnosed. So this is what we understand, that once you are not reacting nicely to some of the medications, it might be the case that the patients are not living with that specific disease, or probably there are comorbid diseases also. So this might be also the case for the follow-up. And in reimbursement, there might be also some difficulties because there's a monotherapy dominance. Next slide, please. Yeah, so the Czech Republic, I already referred to Pavel Janssen, Prague, and some of their activities, but they also worked a little bit on the updated treatment guidelines. And I think we already heard some of the burdens of PAH from Japan, and it's nicely reiterating such kind of statements we already heard, that the PAH has a very big impact, financial impact on people living with the disease, also on their work engagement. This is the second article is about. Next slide, please. To have some colorful pictures, I brought Hungary from this perspective. However, I know that there are other activities. On the left-hand side, you can see nice collaboration with the transplantation organization in Hungary. They are really relying on Dora's expertise, who is also a transplanted PH patient. And on the middle and the right-hand side, you can see some of raising awareness activities, which I think also important and put Hungary on the map in terms of active participation and advocacy. Next slide, please. Poland, the biggest sea region country, so there might be lots of interesting news from their end. But I need to emphasize that this report I'm providing in sea regions might not be complete and might not include the most important ones. It is based on, as I mentioned, some research and so on. But I think some of the topics might be a kind of heads up. So one of them is this reimbursement issue. I already talked about this. I contacted Merck and they said that actually this is not the case, which can be seen in this slide. So it is not reimbursed in Poland. So I'm waiting for the very last and final judgment on this. I do not know what the exact situation in Poland. However, there is also some nice publication on expert consensus on emerging therapies also in the Polish Heart Journal I already referred to. And I think COVID is also a very interesting topic, especially on long COVID, how the patients have been impacted. We already have some publications, but I think from helicopter view, it might be also an interesting topic. Next slide, please. Romania, and I see that we have a representative from Romania, and I think you are also on the picture next to Bogdan. As I mentioned, Romania it's a very big country, and sadly, in the past there were not many activities, or probably there were activities, but was not very visible outside the country. But I can bring, luckily, three pieces of information in terms of Romania. So on the left-hand side, that it was included in PHA Europe's Good News, there was nice advocacy activity with the coalition of organization of patients with chronic disorders. So you can see that PH patients were working together with other disease areas. And on the right-hand side, you can see two programs related to PH. The bottom one is a Romanian European dialogue. It was PHA Europe, which participated and contributed to that one. It happened in Târgu Mureș. The other one happened in Timișoara. I was invited to speak there, but due to other commitments, I could not make it. But this is also another PH-related event. And I'm really happy to see that patients are involved and they are participating also, not as only an audience, but also as a speaker or part of a panel. Next slide, please. And I think that that will be the last one. And apologies if it were a little bit more than expected, but I think Slovakia should not be missed. It's a time of running marathons and half marathons. And it's good to see that many advocates and ambassadors are participating to raise awareness in Slovakia. But also, it's important to underline that Bratislava is a very important center for CTEP patients, and they are part of international cooperation. And with that, I would like to thank for your attention, and apologies again for the technical problems.
No problem at all. Thank you very much, Gargale, for your persistence in coming back to finish it. And that way we'll be able to cut and make a recording of the entire presentation and excuse me, cut those other parts out. There from Turkey says thank you very much. And if anyone else has any other last words, if not, I'd like to thank you for tuning in today, for sticking around to the end, for supporting the Alliance for PH, and we're looking forward to seeing you back in 2026. Have a good end of the year, a good close to your year. All the best to you and your family. And yeah, on behalf of the Alliance for PH, Happy New Year, and we'll see you in 2026. Thanks very much.
Thank you. Bye-bye.
Thanks.